Besides Tuesday, Wednesday I'm available for those who need a little bit more one-to-one or group-of-one, whatever. And that'll be from 10 to 12. If Professor Basile is available anytime on Monday, she will tell you when she is. But Tuesday and Wednesday.
What time on Tuesday?
Tuesday, it's going to be right after class. I'm going to do it during the time frame that you're here.
Yeah, class.
I don't do.
Oh, so it's
I'm
like
doing it at the
lunch.
time that you're in class.
Oh,
Okay, I'm going to get our information together. I know you have things you need to do, other classes. So when I do my lectures, and since the whole test is mine, when I do the comprehensive, it'll be the last 45 minutes or hour, and I will highlight those things you need to know and be put together. Okay, CVA. Cerebral vascular attack, also called CVI, cerebral vascular incident, but you primarily have heard it by stroke, layman's term, or CVA. It's some disruption in the blood supply, be it ischemia, or it could be hemorrhagic. Okay? There are some causes, and if I say this is something additive that you may need to know, I will say that. There isn't a lot of questions on CVA on this next test. There isn't a lot of questions, meaning maybe 2 or 3 that are needs to know. Because you're going to get CVA more so in block 4 because it is an acute event. People generally, sometimes they may be to your non-monitored units, but primarily they are in ICU. Okay, some of the causes of cerebral vascular incident is thrombosis. Who is at risk for thrombosis to occur? Post-op patients. What do we do to prevent that thrombosis from occurring? What medications do?
Lovenox.
Lovenox. When they go home, what medication are they going home on to prevent clot?
Coumadin.
Okay. What are some things you can encourage them to do to prevent the aggregation of coming together of those platelets?
Get them up and
Okay. And what type of activity?
walking.
Just walk. Get some activity going. So, you said to me post-op patients are highest risk because they're sedentary. So, we talked about medications to prevent the clot from forming, the Coumadin. They may be on Coumadin when they go home, and those antiplatelet aggregates. Might just be aspirin. Might be something like Ticlet. You're not having to remember. You don't have to remember these names, y'all. I'm just letting you know that's the correlation. Okay. Thrombosis can be a problem. It's not so much the thrombosis, but what is the what can the thrombosis turn into? Emboli. And go to not only the brain, but also the lungs. It can also go to heart, lungs, and brain. So, cerebral embolism. Stenosis of an artery supplying the brain. Stenosis can occur as a result of plaque buildup within that artery. And you saw a picture when we were talking about cardiac. That plaque builds up, it hardens within the intima of that artery, and before you know it, you're not getting the perfusion. And along with that, as that plaque builds up, that blood vessel becomes hardened, and the pressure builds up. So that is a precursor for CVA. Cerebral hemorrhage. What disorders did you, second week of school, what disorders would predispose that I covered that would predispose someone for cerebral hemorrhage? Thrombocytopenia, not enough.
Platelets.
Platelets. Also, what is one that the person doesn't have any symptoms, but yet they could be walking around, usually associated with African American?
Hypertension.
Hypertension. That can be a reason for cerebral hemorrhage. we do for those people, well, we're getting to it. Risk factors, hypertension. Hypertension, silent killer. People may have had hypertension for the longest, then all of a sudden they come in with stroke symptoms. Before they have a stroke, they can have a TIA. What is a TIA? Transient ischemic attack. Mimics a stroke, but it's reversible. It goes away. Patients, you might go in on Monday, you've had them on Monday, you're working a 3-day shift, and then on Wednesday you go in and they're showing symptoms of stroke. And we're going to get into some of those symptoms. Okay. Previous TIAs. Okay. A person who has frequent TIAs is high risk for having a CVA. So they'll put them on different medications that we're going to be talking about to prevent the occurrence of cardiac disease, atherosclerosis, the plaque builds up, the fat builds up, arrhythmias, because you have some arrhythmias that predispose a patient where the heart's not getting that cardiac output to the periphery. It can be various arrhythmias. The word is arrhythmias, but you have heard dysarrhythmias. So if you have someone who is having a PVC, I just said that, you've seen it where they're premature ventricular contraction, that's just one of them. That person is not getting the heart is not getting the supply that it needs, and you're definitely not getting that appropriate peripheral perfusion. Advanced age, why?
Everything slows down.
Everything slows down, and they have comorbidities. They may have hypertension, CHF, plus they got a respiratory condition, plus a vascular condition. Diabetes is associated with a lot of the CVAs because some people walk around and don't know they have diabetes, along with the hypertension. Diabetes affects the microvascular and the macrovascular. So someone with diabetes in conjunction with having maybe hypertension is high risk for CVA. So what ethnicity is high risk for CVA? Have it all, okay? Signs and symptoms. First of all, let's get back up here. Relative to hypertension, they're going to put them on certain medications, and we'll get more into it. But what medications are we going to put them on? All those any of those antihypertensive meds. But before they go on the meds, what dietary changes could you encourage them to do? Low sodium, low lipid, low cholesterol, low cholesterol, low sodium diet. Okay. Previous TIA, what might be done with those individuals is you might put them on those anti-platelet aggregates, which might be aspirin, which tickle it. It was on the PowerPoint. Just remember there's some correlation there. If it is a blood discourager, if they have sickle cell, why are they predisposed for a transient ischemic attack or a CVA?
Clotting.
The clotting, because you have those sickle cell erythrocytes coming together, which can be a thrombus, and then an embolism. Okay, signs and symptoms. The symptoms are going to manifest as the result of the size and the site of the lesion. It depends on what's surface within the cerebral area is affected. That's the main thing. I'll say it again. Highly dependent upon size and site of location. Okay. With motor loss, the term is hemiplegia. So what if you saw me and I had hemiplegia, what would you notice different?
One side would be maybe not working.
I might have paresthesia, and I might just have paralysis. There's asymmetry. This was the side affected, side of the brain was affected?
Opposite.
The opposite.
My left side is affected, it's manifested on the right. Because of the switch over. Okay, motor, paralysis on one side of, and there's asymmetry. Hemiparesis is the weakness. So, this person's a safety risk. Motor. So, you need to assist them with ADLs. Assist, not do them all, depending on the degree of the disability. This is at any time during the scope of their recovery, their existence and recovery. What can you do to prevent contraction? If this side was affected and I'm like this, what could you do? Range of motion. What can you put in my hand? A ball or a roll, roll towel. Change the towel. I've been in a lot of nursing homes and hospitals where if you're using a towel, make sure that is a clean towel each time, because some people can't squeeze, so the ball may not work. It depends on the debilitated state of that person. So you want to put something in the hand. Okay, you still are going to do cap refill. You're still going to check temperature, but range of motion per the tolerance of that patient. What ancillary service is going to be monitoring the degree of motor function? Physical therapy and occupational therapy, because those things that they need to do, like depending on their level of disability, they may need to dress themselves. They may need to cook for themselves, simple little meals, toiletry. So it's a conjunction of physical therapy and occupational therapy. Okay, communication loss. Who would that be? What ancillary service?
Speech.
Speech therapy. What else would speech therapy be working with besides speech? Swallowing. These people who have problems with swallowing, what do you need to be careful of? What aspiration? Aspiration. So they have a disability in taking thin fluids. What did we say the other day? Our fluids are going to be thick. Whatever physical therapy, occupational therapy, or speech therapy initiates, the nursing staff needs to continue. It's not enough for the nurse to say, "Oh, physical therapy will be here in a minute. We'll get this patient up to the chair." Physical therapy may come only 2 times a day. If that person needs to be transferred to a chair, be it a bedside commode, be it transferred to just sit on the side of the bed as a activity building with this person, nurses need to follow through. That means you need to be there when physical therapy is there to see what the progress is. It's not enough to read the progress notes. You need to be there. And include the family, if possible, when physical therapy is there, or any of these other therapies. Aphasia, what does that mean to you?
Can't speak.
Remember the S in there, they can't say stuff, or say it, or hear. They can hear, but they don't know what a person is saying. Like with receptive, they can't understand you. Lights on, but their inability to understand the spoken word. So what could you do with this person if they can't understand it, but their memory may be there, but what could you do? Let's say this person is used to, they have family that visit, but they may not recognize the family when the family's gone, and you're trying to reorient them. What could you have in their room? Pictures of that family. Or if their family includes an animal, have that animal in a picture, or if admissible, have the animal visit in the facility. So the person has the inability to understand the spoken word. Expressive. Yes.
Would they be able to understand like the written word then? Like they read and understand?
Inability to understand the spoken.
It depends on the degree. And then
It depends on the degree or the area affected. But one thing about it is, they may be able to read it, but they may not be able to understand it. They can say every word, but the connection there is not there. So you want pictures. You still can talk to them as though facing them like if they did understand, but you need to have that added support of pictures there. Expressive. And with expressive, some people can utter certain sounds with speech therapy working with them, but some you can ask them questions. And by the way, you want to use short questions, short sentences, so they can respond. So with expressive, I could say to this person, it's time to eat. Let's go eat. And the person may not want to eat at that time. So the best thing you need to do, if they're able to speak to you, allow them time. Remember this, allow them time to enunciate, allow them time for you to listen to them. Because they can finally get it out. Like sometimes we tease ourselves and say, spit it out. They want to spit it out so badly, but there has to be connection of what do I need to say to this person in response. And then they have to connect what words will fit this situation. So it's all slow. So you need to allow time for this person to do that. So if they're having a problem in expressing themselves, what behaviors might you see in this person? What
Agitation?
Agitation. And as they become agitated, what happens to their speech?
Gets worse.
It's worse. So that's why you want to allow them time. Remember, receptive is inability to understand, to receive that vocal impulse. Expressive is they hear you, but it's hard to communicate back to you. And some people may have the ability after a rehab to do little words or gestures. Now, gestures, I've taken care of stroke patients in the hospital setting, and they've been through rehab, but they still have a difficulty in expressing. They have the expressive aphasia. So, I go in the room in my greens grass days. I go in the room to this little lady, and she happened to be Hispanic. And I went in the room, and back in the day I kept up my Spanish, so I knew what she was saying. And my preceptor went in the room with me, and this lady was trying to tell us, I need to be changed. I need to be changed. And change. I did not say the word change in Spanish. I wasn't the one to be translating. So she knew I wasn't up on my Spanish. So finally she used the word I won't use here in Spanish to let us know that she needed to be clean. Then she said a few verbal little cuss words to me. I understood that. So I told her I was sorry in Spanish. And just by me expressing to her, saying I'm sorry and going through when cleaning her, I built a rapport with her. I learned her nonverbal and her gestures. She used a lot of gestures. She was 70, I think she was more near 80. And she had her her grandchildren and some of her older children come in, and they used a lot of gestures, and she used a lot to us. Hand gesture. Okay. She did a lot. Okay, vision loss. The term in your book is H-E-M-I, H-E-M-I, A-N-O-P-S-I-A. Hemianopsia. There's an O in there. They have a vision problem, usually unilateral, where they can't see on one side. So if I have that brain attack or brain incident on my right side of the brain, okay, on the left side of the brain, see, not a problem. Okay, it would manifest on the right. So I would have visual problems to the periphery. So how could you help me as a nurse? What, for safety, what would you do? If I can't see to this side and I'm in the rehab on phase, or I've been through rehab, if my phone is ringing, where would you put my phone?
On the
Right
left
from
side.
you.
Okay? Where would you approach me?
From the left.
Eventually, we're going to have this person work toward looking to the right. But initially, for safety, promoting patient integrity psychologically, and making sure that that patient can assist with their care for their level, you want to approach them and work with them on the side that they can see. Would you still do pupil checks? Yes. But just be in tune to the fact that even though you do pupillary checks, the site that's affected, the pupil might be a little bit different. And know that the person can't see to that side at this time. Sensory loss. They may have neuropathy. And if they have neuropathy, let's say you're giving them a bath, they're assisting with their bath. It's up to you as the nurse to make sure that the water in the sink, or if they are getting in a little tub with a bench, you make sure that temperature, because they don't have the sensation necessary to determine if that's too hot of water or too cold. Some, if it affects the part of the brain relative to smell, they can't. Their olfactory nerve is affected somewhere in the brain. The thing is, they can't smell. So this is the one where this is a person, if they live alone and they've had a stroke and it affected their smell, sense of smell, they need to have what? Protective. They need to have smoke detectors.
Loud.
They may be a person where they may need these help dogs that alerts them to if there's a smell of smoke. And smoke can be in the form of not only fire, but gas, so they may need animal assist, or just family, have someone assisted with them in their home. Bladder impairment. This is where you'll hear the term neurogenic bladder. Neurogenic. The bladder is malfunctioning as a result of the nerve innervation to the bladder is not up to par. So this person may have a problem with incontinency. They just don't know when they need to go, they just go. Or on the other end of the spectrum, they may have full bladder, you need to do a bladder scan, and they got well over 1,000 in that bladder. Okay. Because of the nerve innervation. They can't sense when they need to go, or they can't sense when they need to empty. So what might this person be a candidate for? If they retain, what might you like to be doing periodically? Yeah,
Straight calf.
Okay, or for a while you might have a folding in for a length of time. But intermittent is the choice because if you leave that catheter in, there's a risk for what?
UTI.
We already know that there's an impairment of mental activity. The person, their judgment, their affect may be off. You go in and you might see that they automatically are laughing and there's nothing to laugh about in the room. At least you think. But to them, they just laugh. Or they cry. Just spontaneously start crying. And if they have the aphasia and you're trying to ask them, it seems as though you're sad today. They're having a problem expressing it to you, but they don't know why they're crying. They may not know why they're laughing, but sometimes when you have patients, you know why they're laughing. It may be at you. Okay? With the CBA, the manifestations that occur, a person may not have all the manifestations. They may have just one thing, the slurred speech that they have, and that's the residual that they have after the stroke. Slurred speech. So one of the things, someone's going into a stroke is they may develop slurred speech. I'm going to tell you from the head down. They may develop slurred speech. There may begin to be asymmetry of the face, where there's paralysis on one side. You see that they can't control their drooling on one side. You may see the tongue just kind of hang out of the corner of the affected side. So drooling, tongue hanging to the side, asymmetry of the face, slurred speech. They may, with that slurred speech, they may manifest via receptive or expressive aphasia. There may be some paresthesia, but usually if it's a full-blown stroke, there is some hemiplegia. There's going to be asymmetry of the sides, the limbs. They just become a limb. Or stiff, but primarily it's going to be, if it's stiff, they don't have any strength. It's like this. They're just hanging there. So what do you need to do with this person? God forbid. But if I was up here lecturing one day and Professor Bethune was not here, okay, and I come in and I'm having more difficulty than when it's a regular day, and I'm just slurring, and you notice that my lips are to the side, and I'm drooling over here, and then you notice that all of a sudden when I walk, one of my legs is just dragging. I'm a safety problem. What would you do? Just look at me and say, I didn't like her no way? What would you do? Sit me down, but you wouldn't call 911 just yet if it's in this classroom. You need to hightail it up there, have the secretary know what's going on. Someone's up here with me, sit me down, so I don't have no controls on one side, so I'm going to fall. So I would hope some of you would get me somewhere, put me up against the wall, so that the wall support. And if I stop breathing, what are y'all going to do? Please make it someone who knows CPR.
Ken?
Holy water, I don't know. But you would resume CPR. All of you are CPR certified. So if that occurred, you'd have instructors come down here. They would have called PD on campus and 911. How are you going to support me? If I'm not breathing, what's the best way to facilitate? The first way to facilitate me to breathe.
Open your airway.
Position the head. Then someone might start CPR. I can't breathe. What if my heart stops? You go through the whole thing. And it's not the time, that would be the time I didn't know it was a student. Y'all would be doing compressions. Okay, so, all that being said, if you see someone in the mall, you know CPR. if you sense that they're having a stroke, you better be performing your CPR. If it's airway, you need to get that airway, maintain that airway too, until EMS comes. If the heart stops for some reason because they have comorbidities, you better be doing those compressions. These days and times, if the respiratory is not the problem, it's compression, 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 compression. And it's not the time for you to say, this person isn't. I don't want to button that shirt. Honey, if you don't, and I die, I'll come back. Okay. But the thing is, you want to do CPR. Basic. Okay? Then you can expect EMS to come. Like the hardest muscle, neuro, you gotta get them to the hospital within a time frame. If it is determined when they get there, they do the CAT scan and they notice that it was hemorrhagic, what med might they give this person if there's a clot in there after they've assessed if this person has had if they've had any head surgery, any surgeries to the head, or they've had this medication before. What might be given to this person after they've done all the diagnosis? Someone said it after.
TP.
Huh? A thrombolytic, possibly.
Did you say a hemorrhagic or did
No.
you mean ischemic?
Ischemic, I'm sorry. Ischemic, thank you. Ischemic. Not enough oxygen. A clot has formed, it's becoming immobilized, it's lodged in my brain.
They gonna kill somebody if they do what you said.
So they'll take you to the hospital. And basically what will happen after they do the CAT scan, if it's ischemic, they can deal with that locally. If it's hemorrhagic, because I also have, if I have hypertension and other comorbidities, they're flying me out. They're getting me out of there. Because what is needed to get that pressure, the pressure that's built up from the bleeding,
Hole
they
in your
may
head?
have,
A hole in your head?
yeah, boreholes, aggressive therapy. So, if it's ischemic, question.
So you mean as far as like if this patient came to Casa Grande Hospital, that they'd be flown out?
If it was hemorrhagic,
So they would have to go to like a trauma center? Okay.
ischemics we have kept because you can give them thrombolytics and you can take care of that process. And we don't have physicians that are trained in the hemorrhagic type. Yes.
Now the evidence base has shown that persons who are either taken or transferred to a stroke certified facility have a better chance of a better outcome, patient outcomes when they are transferred to a stroke certified facility. So like in the Valley, I know, who was that? Barrows, St. Joe's, Mercy Gilbert, think Chandler, and I can't remember which one of the Banner hospitals. So if they are within so many miles of those facilities, they will choose to take them there versus to the local hospital because they have staff, physicians, your nurses who are certified in taking care of stroke patients.
And in addition, at Casa Grande right now, we just started in the last 2 to 3 months. It's TELE, T-E-L-E, T-E-L-E, stroke. It's in conjunction with Mayo Hospital, and the physician. There's a televised visualization of the patient, and they tell us based on all the diagnostics and what they see with that patient. They can tell us if that person is a candidate for their stroke rehab. And what we do is transfer that patient right to Mayo.
Yeah, they got it.
All right. Then, okay, there's rehab, as we said, which is for this person once they get in the hospital setting, be it ischemic or hemorrhagic, depending on what's going on with that patient. Let's work with ischemic right now. You'll have physical therapy that will do a preliminary valve. You'll have occupational therapy, which will deal with speech and swallowing. And then you also will have occupational physical therapy, and there's one more speech. Okay. Anyway, these individuals will also have respiratory, because if the center of the brain that affects the activation for the person to sense that they need to breathe, respiratory will be working with this person too. One of the biggest things that we need to watch when a person goes into a stroke, if the tongue does not deviate to the side, or if you don't position the head of the patient appropriately to open up that airway, the tongue becomes the obstruction. So I say that because during the phase of caring for this patient, you never, the word is never, you never want to leave them any length of time flat on their back. You always want to turn them every 1 to 2 hours, position them, put cushions, pillows, and you want to do that range of motion. While they're in the recovery phase, we're going to be making sure that the blood pressure stays within normal range. So you don't want that blood pressure to go over what?
120 over.
What, 140 over? Some people are saying 90, but
90.
hey, it's getting up there. But the thing about it, you definitely want to watch that diastolic. Because the closer the diastolic gets to the systolic, that's more pressure. The person can go right back into a stroke because of this ischemic. If it was ischemic, if it's hemorrhagic, that blood is the pressure that's causing it. The patient may have some headache and some nausea or vomiting. So if that be the case, what will you be putting down that patient if ordered by the physician to get that GI system before they start on foods? What would they be placing? What food will you be putting down? Every food. Initially. As the stomach is being decompressed over time, due to the follow-up with speech therapy relative to their swallowing ability, they will be started on fluids. They will not be started on clear liquid. If it is clear liquid, then it will be added to it to increase the consistency. After that, what soft foods would you expect them to take? Say they're on a soft diet. What do we serve the patients in the hospital? Parade or puddings. At breakfast times, they may, if it's soft now, you progress it soft, it might be the cream of wheat. It might be, it's not the time to give them coarse oatmeal. Okay? It's going to be cream. As they progressed on, it will be not only parade, but it will be ground. Because parade has more water content, it's more almost like a fluid. They may be on NG or PEG feedings for a while until the person progresses in their rehab. If the person lost consciousness and it affected where the person was in coma, you still have to do total care with this person, even nutritional support as I stated. Now, if this person is in a rehab center and say they're on a ventilator say they are in that coma, the longer they are in that coma, the longer is the incidence of things coming out of it. The longer they're on a ventilator, it's going to be that much harder to wean them, meaning getting them off that ventilator. However, people believe in miracles. They believe in the holy water, huh, kid? And the thing is, there are, let those people express that. They're not in denial. They have a right to be thinking that I'm looking at the bigger picture and trying to think positively, even though I know that things can degenerate. Okay. So, that's the question. What do you need to do with the patient? Validate their feelings. It may not be a denial. Don't say, oh, you're in denial. You need to. No, validate their feelings. Okay, I'm not going to go into the hemorrhagic, the increased intracranial pressure. So, the main things you need to do with this patient, keep the patient alive. If I was in the front of the class here, I would pulse. They'd say it was me. Let's change back to that. And I'm in front of the class and I'm acting weird, which I can act weird anyway, but it's not my weirdness, and you notice I just slump down, and you see the asymmetry of the limbs, of the face, I'm drooling, slurred speech. You better be doing something. And if you notice all of a sudden I lose consciousness and my chest is not rising, you better be doing CPR. Keep me alive. When EMS gets me, when we get to the hospital, they're going to do more advanced treatments to keep me alive. But if our hospital locally does not have the medical staff on to take care of the type of stroke and the extent of the stroke that I had, I'm being transferred out. Okay. Minimize cerebral damage by providing adequate oxygenated blood to the brain. Just in CPR, you're giving me O2 when I get to the hospital setting. It may not be nasal cannula. If I'm truly out, I might be a candidate for EZ tube. Okay, with supplement, with O2 supply. If it happened in this classroom, I would hope y'all know, document. You're not in a role as my nurse, but you're my nursing students, future nurses. Who does that information in an SBAR form need to be given to? To EMS, so that they can know. You guys don't know my medical history. You don't know what meds I'm on. But if I was on meds, when I get to the hospital, they'll be notifying my family. Matter of fact, and this would fall not only for me, but anybody, any setting. You want to get that family on board so there can be some decisions made as to what type of care, because I can't speak for myself. At this point in my life, my alert mother would be the one who has power of attorney. If I had kids, it would be the oldest child if my mom is not available. Later on in my life, it won't be my mom or my kid. It'll be somebody else. But that person would have permission to speak for me. If you don't have any papers, if I don't have any papers formed or anything as to who has power of attorney, it will be the next of kin. But if there's no paperwork or anything, the physicians are going to make a decision. There's a need for care. 2 physicians will make a decision to do what needs to be done with that. Level of consciousness, you know the stages of level of consciousness. The coma all the way up to alertness. Okay, pupil size in reaction to light. Okay, so you're going to do the PERLA. I would expect you guys as nurses students to start doing it. It might happen here in the classroom. Patient's response to command. Okay, can I
understand what you're saying. If I understand what you're saying, can I vocalize it back to you? What needs to be discussed? What I vocalize back to you is it's slurred. Okay. Movement and strength. What would you guys do as far as movement and strength? What would you assess? What would you do?
Grips.
Grips? If my legs work, that's just what he's going to do.
Have you pushed?
Push.
Push. Some people like push right out of the seat. No. Movement and strength. Patient's vital signs. We don't have nothing in here. But what could you take without a machine?
Pulse.
Respirations. Pulse. Respirations. Pulse. Could I not have a pulse?
No. Can you not have
Not have a stroke?
Yeah, we don't want you to have that.
No, I'm not gonna have a stroke. I'm just saying, realistically, if something were to occur, I gotta. Okay. If I start with having some slurred speech, and all of a sudden, I just go blank. I'm not responding to you. I'm looking at you. I'm not enunciating anything. And you notice other manifestations are becoming more than, that's a progression of that CBA. So they're going to work with me more aggressively when I get to the hospital setting, because that stroke is making an evolution to be more severe, because I'm manifesting more symptoms. You still want to talk to me, because after rehab and I look at a face and let's say it's Ramsey and he's there, he's not talking to me, I'll remember, I have good memory. After I go through rehab, I'll remember. They tend to remember, but they may not be able to respond and say, that, and I might point to him, and I say this for this reason. There have been people who have had a stroke, and they get the rehab, and then they're a candidate for a skilled nursing facility, and their family was there at the time of the stroke initially. As their neurons are regenerating, they can remember some of the people who were there. They can remember the arguments that perpetrated the CDA occurring. They can remember something. Okay, you guys are going to reorient me, keep me safe. If it's in a hospital setting, you're going to prevent any complications of bed rest. What is that?
Pressure ulcers.
Let's start up here. What's going to happen with my lungs if you keep me on bed rest?
Actively.
I'm going to have diminished breath sound. I might even get a pneumonia if you don't move me around. Or atelectasis. Okay. If it is the heart, if I'm not moving around, I might develop where I'm not getting that adequate circulation throughout the periphery. I'm a candidate for blood clots, the thrombus. Okay, being that I'm a candidate for thrombus, what will you put on my legs to prevent that thrombus from moving? To have holes, you might even put me on Plexipals and SCD.
Yeah.
SCD plus. Okay. Oh, prevent complications of bed rest. What would you assess about the GI and GU? Let's go GI. Bowel sounds. You're going to be listening to bowel sounds. Just because they have a stroke, the GI can still function. I'd be incontinent possibly if I was a patient. So the thing is, you want to promote that care of that incontinency. What if they have a neurogenic bladder and they can't void? What would you expect? You said it all ago. What would you expect me to do? Assess how much I'm retaining of urine. You might have to do intermittent cath. Foot board would prevent what? Foot drop. And you would do the range of motion. Trochanter rolls, to the sides, and you can have a roll towel in the hand to prevent the contraction. and the splints, they used to use those a lot because if a person has a paralysis on the side, the leg wants to, okay, the leg, it wants to alleviate out. Say, this is my foot. It wants to go like this. So they have the rollers to hold it in place. Okay. You're going to turn me every 1 to 2 hours. If I'm in the hospital setting, then I can't do that. You're going to keep me hydrated with IV fluids. Or if I've gone through rehab, but I'm back in the hospital for some reason, you would make sure that you keep my hydration that it is, but you do stick it, because I might have some residual problems with swallowing. Okay, here's these meds. To prevent the stroke from occurring in the first place, you want to do antihypertensive. You want to give antihypertensives during the recovery phase so that they don't go into another stroke. Antibiotics, because if there's some inflammation and infective process that occurs because of, if it's the lungs, maybe a pneumonia sets in, you might have some antibiotics. Seizure control, it's affecting those neurons, the synapse that occurs. You would give me, you guys have heard of a med called Neurontin, gabapentin. It is a preventative med. It's not because of seizures only, but you're giving it for that neuritis, so that it decreases that synapse that is occurring that precludes a seizure. All these little synapses coming around and everything. So you give the Neurontin to ease or soothe those nerve fibers. So I may not have seizures, but it's a preventative thing. Anticoagulants, so clots will occur again. Sedatives and tranquilizers are given because they depress the respiratory center if that person has a problem with the pattern of their breathing. And also, it just gives this person some rest, lets them rest. Okay. Maintain adequate elimination. We talked about that. Foley catheter or intermittent cath. Stool softeners because they're sedentary.
I have a question.
Yeah.
You said you would give the sedatives and tranquilizers, but it says you don't give them.
What am I looking at? Oh! Okay. Okay, sedatives and tranquilizers are not given because they depress the respiratory system. However, you wouldn't give it overall, but if this patient sees it, if they did have a seizure, that would be the only time that you would do it. I'm sorry if I refuse it. Because if you give a sedative or a tranquilizer, are you getting a true picture of the neural status? No. So, but if they go into seizures, you better be giving them something. Thank you. Okay. You want to include family in the care. We're going to take a break here in a minute. And you want it early in the recovery phase, so the family can have buy-in into the progression of this person. You want to know, does this family want this patient to come home? Is the plan to go home and you're working with case management? Are they going home or are they going to a skilled facility? So the focus is going to be different, a little bit different. Are they going to receive care from nursing personnel or is the family going to be the caregiver? Either way you go, include families so they know what's going on. As I said, it's multidisciplinary. It's not only the physicians, not only the ER doc that initially diagnosed, it's not only the primary physician, it is referral docs, the neurologist, the rehab team, which is inclusive of not only the neurologist, but also occupational speech therapy and physical therapy, and respiratory. Okay. And they may even need clergy. And the family may need support group of families with CDA. You want to, okay, where it says learning to use strengths and abilities that are intact to compensate for impaired function. You want to meet the person and work with them per their functional abilities. If they can perform something, let them do it per their level. Don't get into the habit unless they are totally debilitated. You want to assist them and give them some autonomy. You're promoting for independence if that is a focus with this person. And you want to make sure, yes.
To go back to the family and to include them, what about HIPAA?
Okay, remember I said something about, we need to know who has power of attorney. In hospital settings, when they're doing family counseling, they want a spokesperson. That spokesperson needs to be the one who has power of attorney. That person who can speak for that patient now would disperse all that information.
Okay, so they assume the responsibility of, I'm going to tell.
Giving information.
So then if they come out of a coma and they said, I didn't want anyone to know.
That's why it's so important, even at you guys right now, young, that you let people, that person who has power of attorney over you, to know that I don't want other people involved. But things happen and you don't get it done. So that person takes on the role and does as they think. For your welfare. Yeah.
For example, my mom didn't have anything, and she'd gotten in a really good lot. She'd seen a neurosurgeon and stuff, and she was the intensive care unit, and she didn't have that. So all of us kids came together, and I know a lot of people, we were all kind of iffy, like us, about us kids who could have did and stuff, like to make the medical decisions. Obviously, she couldn't, and then she had to finish after that for a very long time. So what we all agreed on is she was married to my stepdad, and we thought if all of us kids would get mad at each other easily, so we agreed that my stepdad would take that place because they were still married at the time. She came out of it and she's like, I don't want him, being there for me. Well, we sat down and talked and we're like, we didn't want to fight, we didn't want the family to fight, but we had to do that. They had to come in, they're like, we need one person first. And they're like, you guys need to pick one person out of the family to be the person that will take care of your mom or make her decisions. And so we agreed, my stepdad. And then it would be my sister, my older sister. And so it's like, it's weird that I see it, how she's saying it, because it happened to us, but that it really happens that way. Like, you just really gotta, I don't know. But now she has a power of attorney.
Okay, this one right here, develop behavior patterns that are likely to present the reoccurrence of symptoms. The patient needs to adhere to the medication, the pharmacological agents that they're taking. If they're smoking, that's not the time to continue to smoke because of the vasoconstriction. They want to reduce day-to-day stress. And like she was mentioning, she said the girl, her siblings did not get along. That'll throw somebody back in the stroke big time, especially if they're talking while they're in the presence of the house. They really would in my time. They get very demonstrative. The diet after the stroke is going to be one that you would have hoped they would start it prior to the stroke, low sodium, low cholesterol. You want them to follow up on any diagnostics they need to have, any lab values. You want them to follow up on speech therapy, all the therapy. You want to encourage the family to seek out and you give them addresses, support groups. You can lead them there, but it's up to them if they will adhere to going there. If a patient is going home, you need to give support to the main caregiver because there can be caregiver role strain in different manifestations that occur. So you want to be there for that. So from all of this, what you need to remember is preventative measures of stroke. Preventative. That's diet, that's activity activities of daily living? What meds would we give as a group, what meds would we give to prevent a stroke from occurring? The same meds are gonna be used after they have a stroke. What are some initial, like I said, what would you do for me up here if that occurred? What are you gonna do at the initial phase if you have a stroke? Maintain life, be it airway, be it cardiac. Two types of strokes, ischemic